This conference will now be recorded.
Starts. Hello, good afternoon, everybody. Okay, good afternoon, everybody. Then we'll start antepartum fetal surveillance, all these things. So first we should know what is the fetal surveillance. It is just a study or monitoring of the fetal before birth, antepartum. It could be the antepartum, intrapartum surveillance. So antepartum, again, it can be early pregnancy and late pregnancy and during delivery. That is also. So antepartum, intrapartum, antepartum again it's early pregnancy and late pregnancy. Very important thing is the mostly in early pregnancy is to know the causes of antepartum. Basically, the congenital malformation, is baby is affected or any that was severe genetic disorder, all these things in early pregnancy. But later on of the pregnancy, it is the fetal well-being. Most of the time, we are concentrating in the later half of the pregnancy, concentrating how his baby is inside the uterus, whether it's there. So, when knowing all these things, whether we can give her or allow to progress pregnancy, or we have to terminate the pregnancy. So that's why we are studying all these things and when the ideal appropriate time for termination of the pregnancy, so that we not harm this baby, all these things. Baby is also delivered and we will get a healthy baby. Why there is antepartum surveillance? Because of all these things, lot of mortality that perinatal mortality is there. That's why that is there. So government or all these things, WHO's plan to monitor the fetal during pregnancy as well as during delivery, so that we can reduce the morbidity or mortality of this also. Main idea, the basic aims and objective to reduce the mortality of the perinatal mortality. That is the main idea. So we are doing all these things to know all these things. First of thing, we have to think that who are the risky patients. Either it could be risks of this maternal risks is there, comorbidities there, maybe heart disease, preeclampsia, diabetes, severe anemia, all these things, chronic cough, renal disease, all these things. So in this case, we think we know this baby will be affected. So if you take care of this baby during pregnancy, again, it will improve the baby's quality, or that is, and sometimes there's malnutrition, all these things is there, IUGR baby is there. If you monitor during antepartum, all these things, we can take care of the what is pitfall or what is necessary for her. So you have to individualize the patient, all these things. Then we'll think of the how to do, how to deliver, how long we can prolong the pregnancy basis. So when we see the IUHR patient, grossly IUHR patient in this case, we try to deliver the baby earliest possible, because we know internal environment inside uterus, nothing is going right, something is wrong inside. So baby need to be delivered early, so that outside environment baby will be all right. It is not always correct. Sometimes it is most of the time if baby is delivered also. But for that we have to make sure baby is sufficiently grown or long maturation. Baby's long maturation is already achieved. So we'll need antepartum fetal surveillance is all these things. We'll monitor early period of what early gestation, what we can do for her. Later on, what are the monitoring will be way of monitor, the clinical monitoring, electronic monitoring, and way to deliver the baby on this thing. So regarding all these things we'll discuss here. That is, So first thing is this what is antepartum? I think it is nothing but as I say evaluation or monitoring of the baby inside the uterus. So it is the evidence-based antepartum fetal evaluation. So this is, I told you, it is basically an object to decrease the perinatal mortality in this thing because it is very high in India, particularly developing country, India, like this Bangladesh, Pakistan. All this thing is very high. So we want to improve the health quality of the perinatal baby or antenatal patient, all these things. So this is all these things. It is the evidence-based antepartum fetal evaluation to decrease the perinatal mortality by the use of valid method or fetal assessment. So I told you majority of fetal that occurs during the antepartum period. So that is also. So maybe some IUD, IUGR, malnourished, all these thing is there, any infection, whatever the cause, but the majority of fetal death occurs in the antepartum period. So the causes are major eye hypoxia. During delivery or before delivery, there is a hypoxia. We know because of causes of hypoxia, majority of all these things, when circulation is not proper and circulation, well, good circulation is also good fetoplacental relation, all these things. If there is any defect in fetoplacenta or placentation, then we will have a decrease of all this. Not only all these things, other factors are also associated, all these things. So major cause of fetal death are chronic fetal hypoxia, maternal complication like hypertension, diabetes, infection. These are very common. Fetal congenital malformation. I told you, fetal congenital malformation. Either they will end up with some defect or end up some IUGR or IUD. So that is the impact of all this. There are some others. We will come detail all these things. That is. Maternal risk factor could be maternal risk factor, fetal risk factor, maybe due to pregnancy related, all these things. So it could be genetic or may acquired, all these things can be occurred, all these things. So indications, maternal birth business, where we'll do the monitoring severely. We know because high risk patients, these are the patients, they are high risk for that fetal asphyxia, intrauterine fetal hypoxia. So all this thing is there. Maternal conditions, all this thing is there that is, where we'll monitor fetus preeclampsia. Preeclampsia because we know there is an abnormal placentation, so the decreased fetal placental insert, decrease with the blood flow. So we'll monitor all these things. Maybe likely to be asphyxious near term or before term or near term or before preterm or the during preterm. Will this? So we have to decide all these things if baby is well or not. Heart disease, again there is an anoxic condition. They cannot provide proper oxygen to the fetus as well for themselves also. So previous unexplained fetal loss already is unexplained. In term patient, near term patient, suddenly patient, there was a IUD. Unexplained, we don't know. Maybe that is a diabetes mellitus. Most of the time, unexplained fetal loss is a diabetes mellitus. Maybe other causes also. Antiphospholipid syndrome, phospholipid syndrome, chronic hypertension, again chronic superimposed eclampsia or chronic hypertension, or chronic renal disease, all these things. I already told diabetes mellitus, all these things there. Pregnancy or pregnancy-induced hypertension, gestational diabetes. So antepartum hemorrhage, again antepartum hemorrhage, there may be abruptio or maybe placenta previa, that is bleeding will be there. So there may be the fetal will be asphyxia if it is a lot of bleeding is there. Maybe rebel time, maybe conceal time. So we'll have this fetal asphyxia. RH isoimmunization again because there is a hemoglobin that RBC. RBC is that is broken up of all the RBC, all these things. When there is RBC is broken up, all these things, that is a destruction of RBC, then we'll have that is anemia, all these things. Not only anemia, again hyperbilirubinemia, all these things will be present. So that again cause of fetal death, all these things. Hydramnios, again, may be associated some other thing. It indicates sometimes, most of the time, hydramnios, fetal hydramnios, as because of that diabetes mellitus, RH incompatibility, some renal pathogens, all this diabetes. So these are the causes, maybe multiple pregnancy, all these things are present. Preterm premature rupture, again there will be maybe twin pregnancy, maybe polyhydrosis, whatever the causes. When there is increased pressure inside the uterus and membrane is weak, there will be membrane rupture of the membrane. So post-term pregnancy, again post-term pregnancy, because of the decreased liquor, meconium liquor, all these things. If it is not delivered at the right time, it is delayed, associated with oligohydramnios meconium. Again, it is a danger for the baby. Danger for the baby. Factors, the decreased fetal movement could be the all these things. Fetal factor, one manifest as decreased fetal movement. That's why we tell patient to count daily fetal movement count. Intra-outside gait restriction, well, that baby will be not move, growing properly. That is also multiple pregnancy. All these things, fetal progress also lead to the that asphyxious baby. All these things. So these are all causes we can test. So how will evaluate the baby inside the uterus? Because we don't know inside the uterus, we cannot see it, all these things. How will know this baby is in danger? Or these are the conditions this patient baby will suffer later on, all these things. So evaluation, either it is clinical, biochemical, biophysical, or cytological. So these are the things we have to see in patient with clinical. Again, we'll see that clinical. So seeing the patient, because in clinical, what we'll see is this is saying the condition of the patient, whether patient is all right or not, all these things. So how we'll know all these things? First thing is made that's matter. During pregnancy, we know patient baby patient weight is very important, that is also. So initial stage, first visit will take the weight of the patient and how much it is growing, that is during the gaining the weight during whole 9 months of pregnancy. So we'll see all these things. So initial first visit weight is very important and how much, though initial stage little bit decrease of weight is there, but later on it will increase gradually. That is ideal. Normally, this ideal weight should 11 to 12, 10 to 12 kg increase is there, but Indian women little bit less, average Indian 9 to 10 kg. That is there. That is. So that is weight gain, but you have to keep in mind that even excessive weight gain is also not good. Maybe it is associated with some other condition. This is rapid gain of weight. Maybe fetus is growing. Maybe that mother, that body is increasing weight. All these things in other way. So that is excessive weight gain is also not good. If it is more than 15 per week or more than 2 kg, then again it is such a suspicious for preeclampsia because extracellular fluid accumulation will be there. That is also. So we'll see all these things and stationary or falling weight gain. So we'll see that is if it is not growing or it is weight is same, then we'll suspect. If it is excess, maybe preeclampsia, diabetes, all these things. We'll think of all these things. Maybe is big size or this patient heart cells is gaining weight, all these things. So that is all this thing you have to do. So stationary or following up with this IUD or IUD, you suspect all these things. Blood pressure, again you'll see blood pressure, whether it is a normal range or if it is increased, that is problem. If it is decreased, that is problem. So we'll see that is whether blood pressure is correct. The fundal height, again that is growth parameter. We can just para-abdomen examination, we can see fundal height. That is. Again, major sympathy fundal height, that is also correlating period of gestation, all these things. Yes, if it is a falling below the 10th, again, we'll think that the baby is maybe likely to suffer some problem during after some time or during pregnancy, maybe that is some asphyxia or something during delivery. Fetal growth restriction on this thing. So if that is chart is there during antenatal, we'll put in the chart all these things. This should fall in this range, not is at the 19th percentile and less than more than 19th percent also suspect some abnormality, less than 10th percentile also suspect some abnormality. So these are the things we have to check during antenatal visit. Abdominal girth, when it is so if it is there, maybe that is abnormal placentation or chronic hypertension, IVG, all these things. If baby is not growing, then we'll see the decreased abdominal girth. Fetal edema, already we have different, could be the physiological also, preeclampsia, anemia, hypopnea, cardiac failure. These are the main things you have to differentiate from each other of this thing. Physiological, we know that preeclampsia is associated with proteinuria, all this. Anemia, hyperproteinemia, then there will be that again there will be edema. Cardiac failure, you know, congestive cardiac failure, the nephrotic syndrome will have edema, all these things. So we have to differentiate from each other, all these things. Physiological evidence, slight degree of bronchial edema, no proteinuria, disappearance of rest, no cardiac, renal, hematological abnormality on investigation. So these are the things we have to see on this thing during antenatal vision. Early pregnancy, again, that is also. But most of the time we want late pregnancy, though it is early pregnancy, investigation is also there. We are checking on this thing, early pregnancy, again 9 to 11 weeks, maternal serum alpha protein, inhibin, HCG, or all these things. These are associated with the Down syndrome or the neural tube defect, all these things. So it has to be done on this thing. We have uh, triple test, quadruple test, all this thing is there, that is also. So that is all these things we have to need to remember, all these things we have. Though we are concentrating on later half of pregnancy, but these are the things we can see on this thing. Other thing is to just know the whether it is a diagnosis of some congenital malformation syndrome, all these things, some congenital malformation. We take chronic village sampling, amniocentesis, chordocentesis, because all these things can be done. In case of chordocentesis, what we are doing is blood transfusion or collecting the blood from umbilical, all this thing is there. Again, intrauterine infusion of blood, all this thing. Amniocentesis, most of you know all these things, what is amniocentesis. Chronic village CVA, CVS, all these things. So these are the things we are doing in early pregnancy. So these are this thing I'm doing early pregnancy. Then amniocentesis, you know all these things, most of will be amniocentesis. These are amniocentesis. Sometimes we'll get short note of what is amniocentesis. It is nothing but amniocentesis taking up doing from the amniotic cavity for certain investigations, all these things. So that is all these things we are taking up. But during this procedure, you are not supposed to poke the baby's head or part or bodies, all these things, because they can injure the baby, all these things. So it is always done under ultrasound, visual, direct vision of ultrasound. When your free placenta is not there, away from placenta, when the free fluid is there or free amniotic fluid is there, you take with all these things. Spinal needle is and aspirate the required amount of all these things. So it's like either diagnostic purpose or therapeutic purpose. Sometimes we'll do in diagnostic purpose also. Not only we'll do amniocentesis, sometimes we'll infuse the saline inside also. So that's so this is all these things. So diagnostic indication, early month of all these things, and this keratin, all these things, error metabolism, all these things. So these are all these things. So that is all these thing is later month of the fetal maturity or decrease of fetal hemoglobin are sensitized mother. So that is these are all these things early pregnancy when it is doing 11 to 12 weeks, all these things. So that if it is detected before 20 weeks, you can terminate the patient legally. That is all. So these are all these things. Therapeutic indications, again, abortion, that is therapeutic. Suppose multiple pregnancies want to reduce the 3-4 embryos that they are inside, the 3-4 sac is there. You want to understand one thing and you want to abort something. So therapeutic indication on this repeated compression uterine. Suppose there is a very polyhydramnios. You want to take out the fluid from amniotic fluid on inside, just aspirate out all these things. So these are the all this second half of deep process. Hydramnios, fetal transfusion, amnio infusion. Amnio infusion you are giving. Suppose the polyhydramnios, you can put the normal saline, which is more or less likely to this the amniotic fluid. So one saline can be normal saline to push into the uterine cavity where there is a very severe oligohydramnios. So fetal transfusion sometime will do this is photosynthesis when we'll do this take sample from the uh, fetal umbilical cord, or you can infuse on this RH incompatibility where there is hemolysis is very high. This is fetal anemia is there. So directly you can infuse blood into this fetal umbilical cord. So that is the chronic villi samples. It is the prenatal diagnosis. It is prenatal diagnosis or early pregnancy diagnosis. We'll take some sample tissue from the Korean photos. All these things. Again, that is a long needle is there. Either you can go through the transcervical or transabdominal. So under the guidance of ultrasound, we'll do on this thing. Small amount of tissue is taken from cornea to villi and sent for cytological or histochemical analysis. Fetal loss, all these things, mandibular deformity, vaginal bleeding, complication. When you're poking, there may be IUD also, or fetal death may also, if it is injured, all these things. Sometimes, if you are taking some tissues, thinking of you are taking some placenta, chorionic, but you are taking some tissue from the embryo. So there may be absence of lip or lip deformity may be there. There may be vaginal bleeding, placental bed from bleeding, and patient may about all these things. That is. So these are the all complication make a confirm, and when you are giving RS negative, madam, better to give the anti-D for anti-D to this mothers. So this is all this thing and doing all this thing. Ultrasound photosynthesis and this photosynthesis, you know, it is photosynthesis taking up the ball from the umbilical cord. You can see here it is on the origin of the umbilical cord, that is a placental bed. It is there. It is relatively less mobile, so that we can poke here. We can transfuse or collect blood. So if you are doing all this free surface of the umbilical, it will slip. It is very difficult to poke the umbilical cord. If you are poking here, it is relatively fixed point, then you can take blood out of this thing. Then accuracy will be more. That is so that is percutaneous umbilical blood sample. Sometimes we'll do transfusion also, blood transfusion also. So if it is RH incompatible fetal anemia is there, that is some cases of hemoglobin blooding, exchange transfusion, all these things, we can do all these things. So photosynthesis. So antepartum surveillance late pregnancy. This is important for you. It is most of the time you need to know what are the antepartum surveillance. Either you'll get the antepartum surveillance, fetal surveillance, long question, or maybe part question, or intrapartum fetal surveillance. So this is very important. That is matter. So antepartum fetal surveillance again same thing. That is all these things. And again, same thing, antepartum fetal surveillance, again, clinical, biochemical, meant to assess the long maturity of biochemical. So aim is to just assess the fetal well-being, how the baby is well. Then we can know it through clinical examination, through some biochemical analysis, or some or biophysical, like ultrasound, all these things, what we have, that is also. So biophysical test all these things. Again, that is a fetal movement count, fetal movement non-stress test, fetal biophysical profile, ultrasound, Doppler ultrasound, vibroecho stimulation, contraction test, or amniotic. These are all the biophysical profile. Fetal movement will tell you how this baby is. That is so how baby is non-stress test NST. NST, fetal biophysical profile, ultrasound, biophysical, Manning score, all these things. So we'll see all these things one by one on this thing. So that is on this thing is it. So fetal movement count, that is clinically we'll know all this thing is there. And that is, so it is a fetal movement count. When there's a later half of the pregnancy, what will tell patient, I'll tell patient, and it says to count the fetal movement, we'll give her one pen and paper. Suppose patient is complaining because decreased fetal movement, per day there should be at least that's 10 movement, 10 to 12 movement in 24, 14, 12 hours, morning to evening, so count all these things. If fetal movement is less, all these things, then she has to count the fetal movement throughout the day. Throughout the day, means she will count 3 times in a day, morning time, after breakfast, afternoon, after lunch, evening, after snacks. So 3 times, again, it will be multiplied, whether it's achieving or not. So this is the fetal movement count. That's a where. So we'll tell patient this. And during this count, all these things, better patient should lie down in patient, put her hand over the abdomen and count this fetal movement, whether she is able to perceive fetal movement or not. So patient, all these things, so take breakfast, she should not be in hypoglycemic after breakfast, let her lie down, most relatively left lateral position, there will not left lateral position should not be inferior vena cava should not be compressed, left lateral position, let her put her hand on abdomen and count for 1 hour after breakfast. 1, 2, 3, 1, 2. We'll give her pen and paper. Moment she counts, we'll put 1 bar like this also. So that again, this moment 1, 2, 3, 4 bars will cross all these things. If she count all these things 3, 4 in first hour, again after lunch, again she will count all this. Likewise, again evening she will count all this. If it exceeds 12, more than 10 to 12, that patient, we assume that baby is normal. All we assume the baby is normal. So that is one this thing called fetal movement count. If she count more than 6 count in first hour after breakfast, again 6, more than 6. Then she need not count the third time because already more than 12 is 10 is over. So this is all this thing that that is the way we tell patient to count the fetal movement count on this thing. So this is all this thing we are telling patient to know all this thing. And of metals, anything if it is a decrease count, let us say the decrease count. So that is again C has to, then you have to subject in another method of fetal counseling or that is surveillance on this thing. So we'll see suspicious all these things. All multiplied parts. So this is all this thing that is loss of total movement, all these things may be patient is. Suppose the decreased movement, loss of movement, then we assume that some baby is not good inside the abdomen. Non-stress test. This is one way of fetal surveillance. Non-stress test. Most of the time we'll get short knot, all these things. Almost alternate exam will get short knot on non-stress test. What is non-stress test? All these things. I think all of you must know all these things. These are so many times we have revised all these things, repeated all these things. So non-stress test is it's called electronic fetal monitoring. It is fetal monitor fetal heart rate in relation to the fetal movement. So we are recording the fetal heart rate. We are recording the fetal heart rate, and that's on this thing during the fetal movement. It is so it is a electronic recording of fetal heart rate. Again, movement also contract movement also will record on this thing. So what is the patient again? Tell her to empty her bladder, lie in the dorsal position, maybe pop-up position. We'll put this electronic monitoring cardiotocograph around her abdomen. Octography around our heart, and that's it, record fetal heart. And then says when we will palpate, simultaneously we will tell patient palpate or examiner can palpate the fetal movement. When sees fetal movement is we will record the fetal heart rate. So we'll record the fetal heart rate, that is also. So we'll see that how much fetal heart is there. That is basic principle is when baby's movement, fetal heart also increases also. So we'll record the increase, how much is the increase and how long it has persisted. So increase should be around 15 beat per minute, and that is increase should, the persistence should be at least 15 seconds. It persists on this thing. If 15 bit minute is increase and that is also persistent for 15 seconds, then it is reactive. So can be used at feeding. This is can be used in any feeding. So reactive anesthetic, the presence of two or fetal movement is there, the fetal heart rate acceleration during the 20 minutes. That is during this examination period is 20 minutes. So if you see electric, that is stressing is there. That is so movement is there, it is marked here, movement, all this thing is marked here. It is when there it is marked fetal movement here, you see increase here. It is increase, it is increase. So that is a two or three, more than two movement during the 20 minutes of this thing. So increase should be at least 15 bit per minute and persistent for more than 15 seconds. So you can see increase is there, it is there. So this is normal, that is fetal movement of this NST is reactive. So this is reactive NST. That is non-reactive. And there is a fetal movement is there. There is fetal movement is there, but there is no increase of fetal heart. You see that is there. Fetal movement is there, but fetal heart rate is there. It indicates something is going wrong inside the uterus, maybe circulation or something. It is wrong. All this thing we need to do for the test all this thing. So sleep period of this, maybe it is sleeping, maybe all this thing. And so for sleeping patient or the sleeping baby, we have other method of doing all these things. So if it is not showing any increase upon this thing, then it is non-reactive anesthesia. Yes, sir. So sometimes I told you during 20 minutes, patient baby may not move at all this thing. So that can be maybe baby is not well or maybe well baby is sleeping, all these things. So that is all these things. That is non-rapid eye movements or non-rapid eye movement, non-rapid eye movement, all these thing is there. For that, you need to stimulate the baby, either you tap on the abdomen or you'll tuning for our the symphysis pubis or non-luminous, all these things, then fetal will be stimulated and it will move. So once it is movement is there, you'll trace the fetal heart record. It is a vibroacoustic stimulation of fetal heart rate. So this is all this thing we are doing for fetal surveillance test, all these things. Deceleration and early deceleration. This is deceleration. When there is a decrease in fetal heart from the baseline. We know this normal baseline fetal heart, so 120 to 160, 160, all this thing. That is the baseline. Is any deviation. A deceleration means decrease from the baseline. If it is a decrease from the baseline and persisting for more than second, 15 seconds, we'll call deceleration. So deceleration. So deceleration could be early deceleration or late deceleration. Early deceleration is all this thing is there. It is sometimes it is in normal delivery also, showing the fetal heart rate onset. Nadir all this. Early deceleration, I'll tell you later in pictures on this thing. Early deceleration is there, but it is during the strong contraction, peak of contraction, fetal heart will drop on this thing. But when contraction subsided, then again it will pick up. That is after during delivery, during head compression. It is transient thing. That is all this thing. So this is early deceleration. Yes, most of the time it is the vagal nerve stimulation, activation, it compression of the fetal head during early labor during partner. So that is uterine contraction. And sometimes there is a ischemic contraction, uterus circulation will stop for a moment, that will be decreased in fetal. Again, moment it relax, again, so I can show you. This is early deceleration. You can see here, this peak of this is contraction, these are contraction, all these things. This is the fetal heart rate. It is a 140 to 160. This contraction, millimeter of mercury, and this peak of contraction, there is a deceleration. Okay, but when the contraction subside, again it comes to normal level. So it is a normal. Early deceleration is not. Even earlier say indicate there could be possible, but it is due to compression, this ischemic uterus contraction will be there. Then, but problem is there in late deceleration that cause fetal acidosis. Here you see at the peak of the contraction, it is not, the deceleration is not there. It started late, all this thing. Almost peak of contraction is started, it continued all this thing. Now this uterus subsided, still it is persisting. Still it is persisting. Now uterus contraction, now it is relaxed uterus here to here. But still this deceleration is persisting. So this is late deceleration. So like that. So this is problematic. These babies need to be delivered immediately. So we have to deliver baby, otherwise there will be IUD on this. So this is all this thing we have to see during this fetal monitoring, all these things. One more deceleration is a variable deceleration. It is there. It is not related with uterine contraction, relaxation. Anytime there will be deceleration on this thing. Most of the time it is due to cord entanglement, the limb or leg or heads or around the cord, or maybe in pregnancy entangled each other. Most or sometimes oligomeral compression of the head, all these things during contraction. So this is mostly variable deceleration is seen in this cord problem or cord entanglement. So early deceleration, it is in early pregnancy due to cord compression. It is not dangerous. You can just monitor the patient. Late deceleration, if you found that the baby has to be delivered because baby is in danger, variable deceleration, you have to individualize the patient, just what is the cause of deceleration, and you have to manage accordingly. Late deceleration, I told you. Late deceleration, I told you it is that the onset is delayed, so maybe at the peak of the contraction, or it continued till uterus contraction is subsided. This is the placental pathology, post-maturity, hypertension, diabetes, placental approach. These are all these things you have. Excessive uterine hypertonic contraction, all these things. You use excess of oxytocin, that is contraction is continued more than 60 seconds, that beyond 60 seconds. Sometime that is it's regional anesthesia. If you give it all these things, then you have all these things. But you have to be careful. If late deceleration is there, you have to deliver the baby. Variable deceleration, I have already told you, it is because of that is variable deceleration, because of it is this cord entanglement on this thing because personal present. By physical pressure, again we have another thing that this is all this thing is NST or nothing. By physical propulsion, it is integrity of central nervous system, all this thing. Here again we have counting five parameters, all these things. One is gross bobimotor, NST, gross bobimotor, magnetic fluid, fetal tone, and that's breathing movement. These are all these things. Each component is, we've got the zero, and that is if absent or anything is there, zero. If it is present, is 2 points. So total will be, with the 5 parameter, total will be 10 point, all these things. So it includes the NST, non-stress, NST, high risk NST, fetal movement, amniotic fluid volume, fetal tone, and that is breathing. So this is all this thing is this. So what I told you, this is a 5 parameter is either it is 0 or it is 2. The non-stress is reactive, then will 2. If it is fetal breathing movement, it is on this thing. Within 30 seconds, if it is at least one bleeding movement is there, breathing movement, then you will go positive. Mark 2, score 2. Gross fetal movement, at least 3 movement. Others, gross movement will be there. That is fetal muscle on this thing. How we'll know all these things? We can be seen at the ultrasound. These are ultrasound picture. Under ultrasound, we'll see all these things. So there's a complete extension and flexion. Either it is head or this, or maybe vertebrate complete extension from one point to other point. Complete extension and flexion. That is also and amniotic fluid volume. Again, we have to address if it is important, all these things. At least two sets. One amniotic fluid volume, again, we will talk about amniotic fluid volume. It is measure vertical amniotic fluid measurement in 4 quadrant. We are doing all these things. If anything is less than 2, then it will mark A. If any one pocket, so less than 2, 0. If it is more than 2, we have put it 2. So anything score about 8 to 10 percent is baby is okay. Not likely to affect the baby, all these things. But if it is score is up to 7, again suspicion is there. So if it is there, that is 8 to 10, we can continue the pregnancy term and that is enough. And we can monitor weekly interval. Suspect is if it is up to score less than 6, then we have to suspect some wrong is going on inside the uterus. If baby is 36 weeks, 36 weeks means fetal long maturity is achieved, then we have to deliver it. How we will know? LS ratio, phosphatidylglycerol ratio, all these things, amniotic fluid, optical density of amniotic fluid, we will discuss later. If fetal 36 week, fetal is mature, then you deliver. Suspicious, again suspicious, if less than 4, it is again baby is in there, not is suspect. It is, I think it is almost, it is suspicious. That is, if it is less than that, again deliver. If it is there, again constant monitoring is required, all these things. If it is less than 2, better to deliver this baby, irrespective of the period of gestation. You cannot survive immediately, otherwise baby will die. This is interpretation we will do on this thing around little scoring on this thing. Modified by person, now again we are having modified by person because sometimes we don't have facilities to do all these things. Sometimes it is time consuming, all these things. So now that is modified by because we do only NST and amniotic fluid index. This is also so good parameter. That is also sensitivity is there. So it is also we can rely on this. So NST and amniotic fluid index. This is all this thing is there. That is so modify instead of doing manning that is 5 parameter because 5 parameter it will take maximum time because each step we have to observe. For breathing you have to 30 seconds, all 30 minutes, all this thing. So that will take time, but this is reliable also. Only this ultrasound NST and that is it will take 30 minutes or amniotic fluid. This is all this thing. So IUGR, again, ultrasound, we are monitoring on this. Biophysical monitoring is there. What we will now assess this? Indirectly, we can assess the growth of the fetus, all these things. If it is IUGR, then again, BPI, abdominal, femur length, all these things, amniotic fluid. This indicates how his baby is, the SE is in single best measurement of the nutrition. Abdominal, if it is a decrease, abdominal circumference is decrease, then it is a malnutrition of the baby. Baby is not getting proper oxygen, malnutrition. All this is there. So liver tissue is left. Liver tissue is during all this thing. Hypostic liver, that is a hypoplastic liver, all these things. So abdominal gut is there. But other thing is head circumference, again, it will not decrease on this malnutrition, all these things. Head is body structure will not decrease, even femur length, all these things is not. Head circumference and this, only observe. So if you take a ratio, you can just predict the IUGR or adult of the health of the baby also. Doppler ultrasound, again, you can directly count the how well-being of the baby. Doppler ultrasound, again, you are taking arterial Doppler, venous Doppler, but mainly umbilical artery, umbilical vein, middle cerebral artery, and ductus venosus. These are the other things we are doing ultrasound, all these things. We are seeing whether circulation is good or not, all these things. If resistance is there, that this resistance index or resistance is more than circulation is not good. That's why we are going to do all these things. So pulsatile index or resistance index. These are the things we are doing and the ultrasound, all these things. Again, Doppler, that's the normal pregnancy ST ratio, systolic and diastolic ratio, PI index, pulsatile index, and resistance index. This is we are studying in case of IUGR, all these high-risk patients to know the fetal well-being, all these things. So this is all these things normally for undergraduate. This is the picture you have to remember all these things. Normal, that is systolic. In peak of the systolic, the blood flow is this. In diastolic also, that is the case. That is you can diastolic. This is in normal, you say diastolic notch here, all this thing. So this is normal, good circulation is there. You see, systolic is more, diastolic is less. That means fetal is getting less blood. Here it is decreased. Here comparison to here, almost half it is decreased. So this is all these things. It is systolic and diastolic. Again, in certain conditions, when there is severe affected baby, what we will find absent. Here there is no diastole. That means there is no flow during diastole. That is it. There is no flow with baby is not getting any circulation. Again, it is reverse flow. Again, there is no flow in direction. Even it is other blood is also coming backward. That is also. So that is all this reverse diastolic velocity. So this is odd. Most of the time, baby will die within few short time. So this is a normal. This is decrease, absent, and it is reversible. You have to. Sometimes you will get MCA question in your post graduation also. This is also. So when asked across very interested about cardiac functions of I told you this is what the patient is breaks upon this thing. So these are the that blood flow, Doppler blood flow you are going to study. For undergraduate, you have to know the systolic, diastolic, and normal flow, that reduced diastolic flow, absent diastolic, and reversible flow. This is answer. So this is all this thing what we pretend it's umbilical. I told you we are doing four vessels, all these thing, umbilical artery and vein, all this thing, middle cerebral and ductus venosus, all this thing. This is all this thing what we have done, umbilical artery that indicate the how much blood supply is there for the baby, all this thing. So increased resistance in pitoplacenta, IUG or placenta previa, you'll find increased resistance, all these things. Middle cerebral, again, it is effect is the respect to hypoxia because it does not affect the dilatation of cerebral vessels, increased diastolic velocity, decrease ST or PI. That is all this mentioned. So baby circulation will be there, but baby will not properly. The ductus venosus, again, that is if it is there, increase. Then you'll find the fetal acidomia. Umbilical vein again it's also increase in the pulsatile flow. The increase that is also is the acid indicate acidemia. Amniotic fluid volume again that is amniotic decrease. Uteroplacental perfusion that is this thing. It indicate indirectly in this thing that is if placental circulation is will have a good amount of amniotic fluid and during this the later half of the pregnancy, maximum time will have amniotic fluid 30 to 40 weeks on this thing. Sorry, 30 to 32 weeks on this thing, on this thing. Gradually it comes decrease, but it is not that amount is decreased too much, less than. So we have to measure amniotic fluid volumes. So oligohydramnios could be due to preeclampsia, IUJ, maybe some rupture or high rupture of the membrane, all these things. Sometimes this renal pathology, we can have the renal cell. So AP, that is this mildew. So how will measure it is? It is calculated by divide performance. When abdomen is, suppose this is abdomen, we will count one upper right, upper left, right, upper left, right, lower right, lower left, all these things. So vertically we will measure this each pocket, the four quadrant, upper left, upper right, lower left, lower right, all these things, and sum up the all. If the sum up all this, suppose you found the left right side, it is 4 centimeter. Here it is 3 centimeter, 3 centimeter. Here 2 centimeter, again it's 9 centimeter, again 5 centimeter is 40, a total is 40. So it is okay, that's normal range is 5 to 25. That's it. But if you find the sum is somewhere it is less 1 centimeter, 1 centimeter, 1 centimeter, and 0 here, then it is less than normal value. So anything less than 5 will say oligohydramnous. Anything more than 25 will call polyhydramnous. In between, 5 to 25 is taken as normal. So 5 to 25 is taken as normal. That is taken as normal. So these are all these things also single depressed pocket. I'm telling you because we have calculated sum of all these things, but again we have separate calculation single pocket. Suppose if you are seeing one pocket, single pocket measuring more than 2, that also it is okay for patient. If it is more than 8, you'll say it is a polyhydramnous. Anything between 2 and 8, single pocket measurement, then it is. If you're able to measure in one pocket, but it is in between 2 to 8 centimeter, then maybe is okay. That is all this thing is. Other test for self-pregnant test is long maturity. Again, this is not only we'll see all these things before we decide. Suppose you'll say NST is not reactive 36 weeks, but we don't know that is fetal long is matured or not. All these things. So before planning to terminate pregnancy, you make sure your long is baby's long is matured. All these things. And again, other thing, essays of severity, errors, incompatibility, all these things. Lily's chart, all these thing is there. So these are all these things you see whether the baby is maturity is there or not. Fetal long maturity, what we are doing, all these things. Again, taking sample from amniotic fluid, that's subjecting all these, that is a test, all these things. So LS ratio, that is more than 4 will just roughly get idea the long is matured. The sec test again, that is will take the sec, and that is so we'll see that is this thing that ring will be bigger, the bubble will there's a see at the top of the limit uh, surface, all these things. Turbidity, again turbidity, all these things. There are other tests also, orange cell, alpha protein, fetal fibrinectin test. These are all these things not there. Amniotic fluid density, optical density at 40 nanograms, that is concerned. So these are so many tests are there, so you can see that is on this thing. Whereas I mentioned, I told you, again that is a whereas isometric side, again you'll see this the degree of hemolysis. If it is a more hemolysis, you'll see the estimate bilirubin on this thing. If it is a so amniotic fluid is a good for the spectrometry examination. It can indicate that that is amount of hemolysis and estimating bilirubin. Optical density difference gives a prediction severe fetal hemolysis. That's why it is. So not only fetal long maturation, again optical density is also indicated of fetal maturation. So these are all these things, summary of antenatal assessment in early, basically congenital malformations. We'll see if they are kind, we'll see whether it can continue pregnancy or what are the management or treatment we can go give her for further pregnancy, continuation of pregnancy. During late pregnancy, again, that is a clinical, biophysical, normal, and continue pregnancy abnormal. We'll do NST biophysicals again, decide accordingly. Basically, NST, if it is a NST is there, that is that's reactive non-reactive. If it is normal, we'll do it weekly interval. If it is abnormal, biophysical profile, all this Manning score, all these things will do. So while biochemical process, again, you'll see if it is not, then you have to terminate this fetal. So this is all about this antenatal fetal surveillance. Most of the time will get questions in every examination, like NST, fetal surveillance, intranatal fetal surveillance, intrapartum, antenatal fetal surveillance, intrapartum, Manning score, modified by Manning score. So what is the fetal distribution, what is late distribution, what is early distribution. So better you go through your book, read all these things. At least if you read today, you will get better idea on this thing. So this is end of our fetal surveillance, antenatal fetal surveillance. Hope you have understood. Read it. Okay, thank you. Stay home, stay safe. Yes. Bye. Oh.
Thank you.